This video will demonstrate a stepwise approach to arthroscopic management of recalcitrant arthrofibrosis, including an arthroscopic posterior capsular release to assist in recovery of terminal extension. Our disclosures can be found here. After establishing anterolateral and anteromedial portals, we begin with debridement of the suprapatellar pouch. This picture shows representative image of an arthrofibrotic suprapatellar pouch with dense adhesions, which we debride using a combination of meniscal biters, arthroscopic shavers, and the radiofrequency probe. We continue on to debridement of the medial gutter, lateral gutter, and the anterior compartment. In these arthrofibrotic knees, anterior portals are often insufficient to perform this debridement, therefore we will often utilize both a supralateral and supromedial portal. We have found blunt dissection with a switching stick as well as dense scar resection with meniscal biters to be an efficient approach to removal of adhesions.
Here we have included labeled images of the anterior compartment after infrapatellar scar tether removal. This is done by debriding off the anterior face of the plateau distal to the anterior meniscal horns to avoid iatrogenic injury. This is an important step to restore knee range of motion.
We then turn to debridement of the intercondylar notch. A careful debridement in this location is important to facilitate safe passage for access to the posterior knee. The senior author prefers to use a modified Gilchrist maneuver to establish access to the posterior knee. Once the posterior compartment is visualized, we first establish a posteromedial portal under arthroscopic visualization using an 18-gauge needle inserted percutaneously to pierce the capsule. This hole is widened using a number 11 surgical blade and blunt dissection. Blunt dissection is utilized to limit the risk of injury to neurovascular structures. This example shows a left knee in a 90-degree flex position where the right side of the screen is posterior and the posteromedial femoral condyle is visible on the left side of the screen.
A meniscal biter is introduced to begin adhesion debridement.
We then sweep with a blunt switching stick posterior to the capsule to establish a safe plane for resection. When the plane of the posterior capsule has been identified, we use a radiofrequency probe to perform the release of the posteromedial capsule. It is important to keep the radiofrequency probe facing the arthroscope and to debride in a posterior to anterior fashion to minimize risk of injury to the gastrocnemius and popliteal vasculature.
The arthroscope is then placed into the posteromedial portal, and a radiofrequency probe is inserted into the anterior working portal to debride the residual dense capsule that is not well visualized centrally until the portals are swapped.
Attention is then turned to the posterolateral compartment. After a posterolateral portal is established under arthroscopic visualization in a similar manner to the posteromedial portal, the thickened posterior capsule is resected in a similar fashion. A low-profile shaver is utilized to further widen the resection window and limit the possibility of recurrence. The posterior capsule release is completed when the gastrocnemius is visualized.
In another example, we demonstrate use of a meniscal biter and shaver to perform the posterior lateral release with a nice view of the gastrocnemius posteriorly.
Here are still images demonstrating completed posterior capsule release with visualization of the gastrocnemius posteriorly. Our final step in sequence of debridement involves establishing a transeptal portal to remove adhesions between the PCL and the posterior capsule with the neurovascular structures immediately posterior. In this example of the left knee, we have placed the arthroscope into the posteromedial portal, posterior to the left, anterior to the right. Through a posterolateral portal, we insert a trocar to bluntly pierce the posterior septum. The portal is then bluntly dilated using a trocar sleeve. We carefully widen this passageway with a low-profile shaver and radiofrequency probe to complete the transeptal portal.
In a recent case example, figures A and B demonstrate preoperative extension and flexion, and figures C and D demonstrate postoperative extension and flexion.
This completes our stepwise approach to debridement of the arthrofibrotic knee utilizing a posterior capsular release. We thank you for your time and attention.